Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AbbVie.
Hello, I'm Dr. Philip Meese, Director of Rheumatology Research at Providence Swedish Medical Center and Clinical Professor at the University of Washington School of Medicine in Seattle, Washington. Welcome to this program titled Advancements in Treatment for Inflammatory Conditions, the Role of Interdisciplinary Coordination in Effective Care Planning. Joining me today are Jamie Knucken, Associate Professor of Medicine and Associate Chair of the Department of Medicine Practice and Systems Transformation and the Division of Gastroenterology and Hepatology at the Mayo Clinic, Florida, in Jacksonville, Florida. Obviously, Jamie is a gastroenterologist. I should mention I'm a rheumatologist. And Sakshi Khatri, who's an associate professor at the Icahn School of Medicine in Mount Sinai Hospital in New York, is double boarded in both dermatology and rheumatology, so a double threat. So in this program, we will be discussing the following: the burden of disease across inflammatory conditions, and notice that we're using the plural. So we're talking about more than just one autoimmune disease, but several autoimmune diseases that can be mixed together and occur simultaneously. We're going to be identifying comorbidities across these inflammatory conditions that require an interdisciplinary treatment approach. So clinicians coming from different disciplines, like we represent in our group today. The best practices for care coordination and interdisciplinary treatment selection, and the approach to collaboration with other members of the interdisciplinary team to provide optimal outcomes for patients living with these multiple inflammatory conditions and comorbidities. As you know, patients with autoimmune disease have a significant burden that is substantial and multifaceted, encompassing significant physical, emotional, and financial challenges that severely impact a patient's quality of life and place a major strain on the healthcare system. The patients often experience chronic and variable symptoms. For example, in rheumatologic autoimmune disease, the patient may have severe pain, overwhelming fatigue, joint stiffness, and cognitive issues. I hear the word brain fog quite a bit in my patients. And these can come and go in flare-ups that can be quite unpredictable. And then obviously, a gastroenterologist may be dealing with patients who have inflammatory bowel disease, Crohn's or ulcerative colitis, which can similarly go through flares, bad diarrhea and abdominal pain at times, and other times not, and with variable responses to treatment. And in dermatologic conditions, for example, psoriasis, same deal. You can have the condition come and go and flaring unpredictably, and oftentimes with inadequate control of disease, even with some of our advanced medications. Because of the unpredictability, patients often feel quite vulnerable, and it's difficult for them to plan their daily routines with the family, with work, and their social life. And so this often leads to a sense of isolation and, again, vulnerability. There can be significant diagnostic delay and frustration with that because the patient's symptoms may not be a textbook case that will lead a primary care physician to say, oh, this is psoriasis, or this is rheumatoid arthritis, or this is Crohn's disease. Instead, there are often overlap of symptoms in these different clinical domains that may frustrate getting to a clear diagnosis, and it may take some time. The other issue that some patients, and I see this a lot, is if a patient has pain and fatigue, they may be considered to have a condition like fibromyalgia. This leads to a significant problem with mental health, and patients may be depressed and anxious, undergo social isolation, and cognitive burnout. And one of the big fears that our patients experience is loss of independence. I can make my morning coffee. I can get to work by myself. I can be sitting at work, and if I have Crohn's disease, then may have urgency that leads me to have to go to the bathroom a lot. So these are all things that impact a patient's sense of self-worth and self-independence. And many of my patients really dislike being in that state. And then finally, there can be a significant financial burden with high healthcare cost, with all the doctor visits, the laboratory test, the cost of medications, and there are many out-of-pocket expenses that occur that may not be covered by insurance. And so this has a big impact on the financial viability of a patient and their family. There may be miscare due to cost. For example, a patient may say, well, I really don't need to go in and have monitoring labs. It's going to cost me an extra copay. And so some of this inattention to getting care may have a deleterious effect on the patient. And of course, the loss of productivity and income that comes from not being able to work as much, not only does this impact the individual, but also their family and others in society. We've done some research that suggests that in the US, the cost of treating autoimmune disease may be over $100 billion. And this doesn't include all the substantial indirect costs, such as lost wages and the need for hired help at home. So with this background and knowing how important it is to effectively treat autoimmune disease, and especially when it's overlapping with other autoimmune diseases and needs collaborative care, let's look at our first case that Jamie is going to introduce to us.
Thank you so much, Philip, for that background and how important it is and the impact that these inflammatory diseases have on patients. We're going to walk through case number one, which will kind of outline maybe some of this crossover. This is a 24-year-old female with a history of inflammatory ileal Crohn's disease that was diagnosed in 2020, so about 5 years ago. At her diagnosis, she presented with symptoms of diarrhea, abdominal pain, diffuse joint pains, but without any visible or X-ray-based joint abnormalities. She was initially initiated on adalimumab and continued on every 2-week dosing. She clinically was able to achieve one of our targets, which is clinical remission. She was able to normalize her fecal calprotectin, which is an objective marker we assess as part of our treat to target strategy in inflammatory bowel disease. And in fact, 3 years in, she had a follow-up colonoscopy that showed that she had absence of ulceration. So she really was reaching all of our targets from a clinical standpoint. But now, a couple of years later, she's presenting with new symptoms of diarrhea and abdominal pain, similar to how she presented initially. We get some objective markers to assess whether or not these symptoms are inflammatory in nature, because people can have diarrhea and abdominal pain for other reasons. And she had an elevated fecal calprotectin. She had an elevated C-reactive protein in her blood. We did infection testing to ensure that that wasn't contributing to her symptoms, and that was negative. And we actually got an adalimumab level to understand why she had done so well and achieved those targets, but now was losing response. And we found that her adalimumab level was 0 and that she had developed a high anti-adalimumab titer or antibody. Objectively, we also did intestinal ultrasound, which we have access to here at Mayo Clinic in Florida. And the imaging that you can see shows active inflammation of the terminal ileum. So she lost response, likely because she had no drug present from the development of anti-drug antibodies. So, given this increased risk that she has now, if you form anti-drug antibodies to one anti-TNF therapy, you are more likely to form them to a second anti-TNF therapy. There was decision to start a more gut selective therapy in this patient. And in our world, and in fact, the only indication for this particular therapy, vedolizumab, is within the Crohn's and the ulcerative colitis world because of the mechanism of action being so selective and how it prevents inflammation or lymphocyte trafficking to the gut, but doesn't necessarily impact other disease states. So it's not helpful in dermatologic conditions and often is not helpful in patients with joint discomfort unless it's secondary to their underlying bowel inflammation. She initiates this therapy with vedolizumab, both induction and maintenance, and she's now able to again achieve clinical response with an improvement in her symptoms, not complete normalization. As well, though, she gets objective assessment with a fecal calprotectin, and she is able to normalize that. So elevated fecal calprotectin was consistent with her inflammation seen on ultrasound. She achieves at least objective targets of inflammatory control with some mild intermittent lingering symptoms that may not be inflammatory in nature. However, now I'm seeing her in follow-up, and she's noticing, based on the image here, some new extraintestinal symptoms that she previously hadn't experienced. She's got a scaly rash on both of her elbows, and now again diffuse joint discomfort, which was similar to how she presented at presentation. So I think, now we're in this situation where we've been able to achieve inflammatory control from the Crohn's standpoint, but now this patient is having new symptoms, rash and joint pains that are obviously impacting her quality of life. And as a young woman, she doesn't desire to have a rash all over her arms. So I guess it's a great discussion because this is where I'm so lucky to have partnership with my rheumatologist and my dermatologist in our practice is what might be happening.
Right. Right, I'll take a stab at it. When you see that scaly erythematous rash on the elbows, which is a classic extensor site, psoriasis obviously comes to mind. Also, given the fact that she has Crohn's disease and, you can have psoriasis overlapping with Crohn's. I hope your dermatology colleague did a biopsy.
So I did send her to see my dermatologist who had given her the more formal diagnosis. What is that diagnosis?
Right. I would suspect it to be psoriasis, but with this, I mean, eczema is always in the differential, though the location is not classic for eczema. I do always do a biopsy, even if clinically it is very obvious what the diagnosis is, just because in such a complicated patient, would that change your decision to think of a different systemic therapy? Right. And if it is psoriasis versus if it is something else. But it does look like a psoriasis or a psoriasis picture. What was it, Jamie?
So she did go and see our dermatologist. She did get a biopsy. So you all went to the same school, and it was consistent with a psoriasis form or psoriasis like lesions. And so then from a joint standpoint, I guess, Philip, if I'm sending you this patient, maybe I wouldn't always send you this patient, but if I was sending you this patient, now she's got this psoriasis like rash and she's got that new onset joint pain that actually previously had resolved. We hadn't had her seen with dermatology, mainly because she didn't have, disfiguration, and she improved so fast with adalimumab that it wasn't necessary.
So this is a fairly classic case for us, and I work really closely with the IBD gastroenterologist in two different systems in our city, the Swedish Medical Center where I work, as well as the University of Washington. And it's very frequent for us to see patients who are have successful control of their bowel disease with vedolizumab, but we know that it's not treating beyond the intestine. And so it's not unusual to see a patient blossom forth with these genetically linked conditions of psoriasis and what we'll likely end up calling psoriatic arthritis. And so what we're going to be ultimately doing is looking for a treatment that can treat all three clinical domains effectively and relatively safely. Or sometimes we see patients that are further down the road and we end up doing dual therapy, where one clinician will prescribe a medication for that particular domain, like vedolizumab, and then while we take on prescribing another agent that can be effective for both the skin and the joints. So one of the things that we've learned over the years is the clinical, genetic, and pathophysiological association between psoriasis, psoriatic arthritis, and inflammatory bowel disease. We know that up to 30% of patients with psoriasis will have psoriatic arthritis, and there are many patients who have psoriasis that may have either overt IBD or what we call subclinical. So if you go in and do a biopsy of the terminal ileum or colon, we may see a dusting of lymphocytes. It's not quite normal. It's not overt IBD, but it's not normal. So there's something about the association between these. And if you look at the IBD and PSA overlap, it's not unusual to see patients with IBD having either what we would call PSA or a oligoarticular oligoenthesial, meaning inflammation where tendons or ligaments insert into bone, a condition that's either peripheral and involving peripheral joints or possibly involving the spine. So it's really important to be aware of this. And in our case, I have the cell phone numbers for both the dermatologist that I work closely with and the gastroenterologist right there, ready to call either themselves or the nurse practitioner that works with them. So now that we recognize that there are significant overlapping genetic factors, cellular pathophysiology, and even clinical features of IBD, psoriasis, and psoriatic arthritis, it's important to recognize that the three may coexist in some way or another. And oftentimes, if the patient starts with having an IBD condition and then later on accumulates psoriasis or psoriatic arthritis, we end up calling it the arthropathy or psoriform changes that can occur with IBD. We give IBD the primacy. And then I am constantly on the phone with my GI and derm colleagues or the nurse practitioners working with them. And we are also communicating through the electronic medical record. And so what I will be thinking will be, well, gee, what medicine can we choose that might cover all three? Any thoughts from you all?
Right. So from a derm perspective, I do tell patients that if your GI disease is being controlled with what you're on, we can certainly optimize topicals and see how it goes. Now, if it goes beyond a body surface area, either switching to a MOA, which will cover everything, or adding on, which then becomes sort of like an off-label dual biologic therapy use, is a consideration and certainly something, Dr. Mees, that you pointed out. But yeah, I mean, pretty much what you said is what we would consider as well. I don't know, Jamie, would you differ with what was discussed?
I think that we're starting a little bit from a different place, right? From my standpoint, her IBD is controlled. So any therapy that we choose as a group, right, in this multidisciplinary approach, we're no longer trying to treat active Crohn's disease and instead maybe treating the active extraintestinal manifestations. In this sense, maybe psoriasis hadn't presented initially with her Crohn's. Adalimumab was keeping that at bay. And then when she discontinued the adalimumab, or basically neutralized for adalimumab, is now when we're seeing this presentation of psoriasis. But from my standpoint, I think I focus on where is the disease activity and where is it the worst. Is this disabling joint discomfort? The rash, we would like to get rid of it, versus is this disabling Crohn's, and where do we need to focus kind of the most effective therapy? So for me, I would defer to rheumatology and dermatology about getting anti-inflammatory on board that's best to treat the psoriasis and the psoriatic arthritis. And if she were to have a relapse of her Crohn's inflammation, despite treating with a therapy that does have an on-label indication, then at that point we can maybe talk about layering back on that medicine that got her under control. The nice thing about, in our world, having such a gut selective therapy is that we feel more comfortable layering these things, even though they're off label. But combination biologic therapy or combination advanced therapy is now becoming something that we're seeing more routine, because we have patients presenting with more than just one disease state. And so I defer kind of to where the most disease activity is, and then allow that expert to make the decision that's best. And then if we need to layer back on, we can.
So I would be thinking about what treatment might cover all three domains, and several come to mind. IL-23 inhibitors, such as guselkumab or risankizumab, are approved for treatment of Crohn's and ulcerative colitis, psoriasis, and psoriatic arthritis. So theoretically, a person on one of these might do very well in all three clinical domains. Another agent that might be considered but doesn't have formal approval in all three domains is the JAK inhibitor upadacitinib, which has indications for Crohn's and ulcerative colitis, as well as psoriatic arthritis, but not psoriasis. So we have some choices. And I will say that sometimes a patient will want to hang on to vedolizumab a little while longer while we're bringing in one of these new therapies, just because they know how well it works in controlling the gut symptoms. So with that very interesting case, which involved interdisciplinary care, Sakshi, do you have some a case that you might share with us that also illustrates the importance of collaborative care?
Yes, thank you so much. So I have another case which sort of is the interface between all our specialties. A 37-year-old male with a long-standing history of ulcerative colitis, no personal history of eczema as a child, but does endorse seasonal allergies. And you might be thinking, why am I throwing these allergies or eczema in the mix? But I'll get to that. And a family history of asthma, basically was sent to me in my dermatology clinic by the gastroenterologist. He was on ustekinumab for almost 2 years with excellent control of his disease. And for the last 6 months had been having this rash on his skin, which was extremely itchy. Initially, it was sort of limited. His gastroenterologist gave him topical clobetasol, which is a topical steroid. It would improve, but it would come back again. And then gradually, even the topical steroid really didn't give him the clearance that he was wanting to get from it. So he comes to see me with this extremely itchy rash, which has, in a sense, taken over his life because he's not able to sleep or do his activities of daily living. When he came to my practice, he had this sort of erythematous scaly rash, a little different from the case that Jamie presented, because it was not localized to the elbows or the knees, which are classic psoriasis sites, but it was sort of diffuse everywhere. The margins were well defined for eczema. So, you start thinking, is it psoriasis? Is it eczema? Psoriasis tends to be not itchy, but though that thought process is changing, there was involvement of the popliteal fossa, the cubital fossa, which are classic sites for eczema. So the clinical diagnosis was eczema. I did do a skin biopsy just to have a definitive diagnosis, just given the history of UC and being on ustekinumab. The biopsy did confirm that this was indeed an eczematous dermatitis, because there was spongiotic dermatitis that was seen on histopathology. So now you have a patient who has UC, is on ustekinumab, is doing rather well, comes in with a new onset skin rash, which is clinically and on an H&E skin biopsy, consistent with eczematous dermatitis. has a family and a personal history of atopy. So the question is, was it the ustekinumab that caused him to have this eczematous dermatitis? Or was this just like a de novo eczema, which even adults can develop for the first time? And these are the clinical images. Margins, you can sort of trace the margins, but they're not as well defined as, that previous case that we discussed. But it is erythematous, excoriated, extremely itchy. Here you could see that the lesions are a little bit more well defined, sort of almost similar to what Jamie showed in that first case of hers. And then that's the histopath, where you could see classic spongiotic dermatitis. Those sort of white areas in the epidermis are the spongiotic dermatitis. So eczema would not be something that's classic that we consider to be a reaction or a paradoxical process from ustekinumab. In fact, there was a phase 2 clinical trial that was done looking at ustekinumab to treat eczematous dermatitis, done almost 10 years ago, which showed that it does improve eczema, but the difference between that and placebo was not statistically significant. So we won't really consider that ustekinumab had anything to do with this patient developing eczematous dermatitis or eczema. So it was more of like his childhood and family history of atopy that contributed to him having eczema. And while we've historically thought that eczema is a childhood disease, in the US adult population, upwards of 7 to 10% of US adults can develop eczema for the first time. We do know that anti-TNFs, which we use both in the GI and the room space for inflammatory conditions, are associated with eczematous dermatitis. And up to 20% of patients on an anti-TNF can have paradoxical eczematous dermatitis. So for me, I discussed this case with the gastroenterologist, going on an anti-TNF to control, to potentially treat his UC, which was in control with ustekinumab, was not an option because that would have certainly made his eczema worse. So as discussed and mentioned, we were thinking of either do we add a more eczema-specific systemic therapy, such as an IL-4 or an IL-13 blocker, or do we change to a different MOA, which is a JAK inhibitor, because that would treat the inflammatory bowel disease as well as the eczematous dermatitis, because we do have one upadacitinib, which is approved for atopic dermatitis and is approved for UC as well. So, as in the previous case, we sort of talked about a patient who had a need for interdisciplinary management.
Wow. And in this case, it's really clear that there's a big need for dermatology to help counsel and guide because of some of the options that you are suggesting about treatment for the eczema are not ones that we know as rheumatologists. And I doubt the gastroenterologists are really aware of them. And I hope that Jamie has your cell phone embedded within her cell phone so that she can give you a quick call. So as in the previous case, we have some choices, some that we are not familiar with, but some that we are, like the JAK inhibitor class of medications. Sounds like it would be effective for treating both conditions, but it's also possible that this is another case where we would need to think about dual biologic therapy. Wow. So we really have underlined here the importance of being able to collaborate closely with your colleagues across the aisle in gastroenterology, dermatology, rheumatology, and in our case, other specialties as well, like ophthalmology in patients that have recurrent uveitis would be another example. So I'm glad that we are having more modern ways of communicating, including the electronic medical record and cell phone to facilitate some of this, but also just getting to know each other is important. So Jamie and Sakshi, thanks for this great discussion. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.